we need these new aims. We need to come back. I would suggest the IHI triple aim, but that's, of course, my bias. But we need to think about how do we put all the pieces together, because they are related. Each one of these areas is related. And I want to take you on a quick tour around the triangle and tell you how I see them related. Let's start with the experience of care. The experience of care, as I mentioned, is all of these things. It's not one. It's all of them. So as an example, we are working with the country of Scotland. The country of Scotland said, we want to be the safest country in the world for a patient to be hospitalized. How do we do that? So we worked with the leaders to create what's called a driver diagram. It's the view of the system. It's how do we look at the system of safety? What does the government need to do? What do boards need to do? What do frontline physicians in the ICU and the operating room need to do? So we created the map, and then just like Ghana, we started in some hospitals with some units, and then we're methodically working through to eliminate the defects in care in Scotland. You can see here that the central line bloodstream infection rate is decreasing year on year, as is the ventilator-associated pneumonia. The thing about these graphs is it's not one unit, it's one country. The whole country's moving at this pace. And C. diff coming down. But you really need to think about the whole system, and that experience of care is so focused on safety. The patients need to feel like they're safe in your hands. So that's one example of how we've been working on safety. I'll jump down to waste and efficiency and see how some of these link. I know you're focused on beds and admissions and how do you keep the right patient in the right place. At Cincinnati Children's, we're working very hard on flow. And the CFO, the finance person, is the person who's saying the best way for us to get better care at lower cost is to make sure that we understand flow, that we're moving the patients through the system at the right pace. Most hospitals I visit, they don't manage flow. Flow happens to them. You know, a patient gets an infection and they get stuck longer. The husband doesn't come to pick up the wife, and so the patient ends up staying over another day. We have no bed on the ICU, so the patient's stuck in a hallway. It happens to us. At Cincinnati Children's, we're learning that you can manage it. It's not a passive system. The leaders are saying the best care requires that we manage flow. And so we redesigned, starting in the operating room. When you book a case at the Cincinnati Children's in the operating room, you don't book the operating room time. You book the pre-op time, the x-ray, if they need one beforehand, the lab work, the pre-admission work, the visit with anesthesia, you visit the operating room time and all the people that are needed. If the patient needs an ICU bed, you book the ICU bed, and all the way down through the discharge. That's what you book. And when you book it that way, you're starting to manage flow. In doing that, we're seeing dramatic reductions in waiting time, even as the flow and the numbers are increasing. So basically what they're saying is they've added on a new OR without needing to build one. They don't need to staff a new building, because when you manage flow, the patients are working through at the right pace. So you can see overtime is decreased. The staff love it. They're not stuck with cases anymore. And so the overall growth is sustained at 7%. They're taking care of 7% more patients with the same capital equipment. And the way we measure it at Cincinnati's is anytime a patient is in the wrong place, they actually call it a flow failure. And they measure them. And this graph is all over the hospital, so that they're counting a patient who's stuck in the wrong bed as a failure. I love that, because it gives everybody the vision that they need to work together to design and then process the patients through at the right pace. So in doing that, you can see that that's allowed them to take care of 78 additional patients per day with the same physical plant and the same staffing levels, because they're not focused on trying to manage all the waste of flow failures. They've eliminated the need for an additional 102 beds. If I were in your shoes today facing the challenges you face, I would start to manage flow. Don't let it happen to you. Step up and use queuing theory, reliable theory, and come into Coahuila to figure out how will we manage flow. And then patient-centeredness, and again, you're going to see how all of these link together. I want to introduce you to a patient I met just 3 weeks ago in Jönköping, Sweden. I was in a hospital called Rehov Hospital. It's about the exact size as Middlemore. And I was making rounds to the hospital as I do, and I came across this unit, and I didn't recognize the unit. So I said, what is this unit? And they said, oh, this is the self-dialysis unit. Now, I know some patients do self-dialysis, sometimes at home, but I'd never seen a self-dialysis building. And so I, of course, started to ask, well, how did this happen? And they said, oh, well, we're just very innovative and all that. And I said, no, really, really. You didn't just build a building and say, okay, everybody in here is going to do their own dialysis. How did it happen? And so I met this guy. His name's Christian. I don't know if you can see him. He was 25 years old in that picture, a young, handsome guy. He's about 31 now. And he was a mechanic at Saab Aerospace. So he was a mechanic that built airline engines for Saab. And a triathlete, warm and wonderful guy. I spent 8 hours with Christian. And I said to Christian, tell me about your story. And he said he got glomerulonephritis and his kidney shut down. And he started to go on dialysis. And he said after a couple of weeks, he said, you know, I want to do this myself. He said, let me hook myself up. And so he did. And the nurse taught him. I'll show you that in a minute. And pretty soon, Christian taught this elderly lady. She was 73 years old. She was in the next bed. And she said, Christian, what are you doing? And he said, I'm doing my own dialysis in Swedish. So she said, well, teach me how to do it. So Christian taught her how to do it. And then the next thing you know, they have an aim that 75% of the patients on dialysis will do it themselves. And currently, they've got 60% of the patients on dialysis. So I became intrigued, and so I started interviewing them. As I said, I spent 8 hours with Christian. And I said, Christian, where did you get the courage to say, I want to hook myself up? And he said, I've been studying kidney failure since I got this disease. And he said, I know that inadequate dialysis is going to cost me 6 years of my life. He said, I'm young. I have dreams for the future. I want a family. And he said, I know that if you adequately dialyze, your life expectancy is longer. And I know that I'm not adequately dialyzed. And he said, I also know that there's a lot of variation in the way that you do it. And he said, I can do it better myself. I'm a mechanic. And so he said, you know, let me hook up my own plumbing. And he said, I want a full life. And he explained to me, which I had forgotten, that post-dialysis syndrome is paralyzing. He said he was spending hours of days every week coming into the dialysis center, and then when you're just a little bit under-dialyzed, then you go home and you end up with post-dialysis syndrome, so you basically go home and go to bed. And he said, my whole life is in a bed, one place or the other. He said, I want to have my life back, and I know I can do it if I do my own dialysis. And he said, I talked about learning and teaching. And then I said to him, like being a nurse and a hospital CEO, well, what about safety, Christian? And he said, well, of course it's safer in my own hands. And that wasn't what I was expecting, to be honest, you know. I was thinking of it from our point of view, which is, well, you know, you're taking risks here. And he said, no, I'm not. First of all, it's my bacteria, so I'm not contaminating myself. And he said, every one of you does it a little different. He said, the variation in the way you approach me drives me crazy. And he said, if I do it myself, I know I'm going to be better off. So then I interviewed Annette. She's the nurse leader. And I said, Annette, where did you get the courage to let this happen? This is PDSA, Plan, Do, Study, Act. This is quality improvement, taking research and putting it into action on the bedside. So she said, I didn't build the building first. I said, well, let's work with Christian. And if Christian can do it, then we'll work with the 73-year-old patient next to him. That's PDSA thinking. It's how do we improve the processes, make it safer for Christian. And so she said, I was also surprised by the design differences. She said that they were thinking about redesigning the unit. And so she said she and a group of physicians and nurses went into breakout sessions and they designed the unit as they thought that the patients would want it. And then Christian knocked on her door and said, why don't we get to have a chance to talk about what we want? And I said, what were the big differences in that? And she said, first of all, we had designed it to look like home. You know, it was warm colors and fabric curtains, and we were going to buy these really expensive lounge chairs and make it look like your living room. And the patient said, God damn it, I'm in the hospital. I don't need that. Just make it look like a clean place, and I'll be fine. And so that's what they did. They said, don't spend the money on expensive chairs and artwork. Spend the money on something that I'll show you in a minute. And that's what they did. They're managing at a half to a third less the cost. So there's your cost, there's your flow. The patients let themselves in with the card key. So they can come in anytime between 5 a.m. and midnight. They let themselves in with the card key, and they go in and they hook themselves up. They run their own dialysis. Then they clean up after themselves, and then they go home. And I said, Christian, why do you clean up your own place? And he said, well, I know I'm going to be coming back in a few days, and I want it to be perfect for me, so I leave it perfect for the next patient. So I said to Annette, well, what do you do nowadays when you don't have anything else to do? And she said, I think about the person. She said, I'm there. She said, I'm now a coach. And she said, one day I looked around the room and I said, there are 17 patients in here right now, and none of them work. She said, they've been devastated by the experience, and they've all lost their jobs. So she said, I started to sit with them, and every patient that comes in here now, I sit with them and I help them write their CV. And then she called in the county's employment bureau, and she said, I think these people can work if they want to. And now all 17 are working. So I said to Christian, did you go back to work at Saab? Are you back working as a mechanic? And he said, no. And I said, oh, you're not working? And he said, oh, no, I'm not. He said, I'm an RN. He went back to nursing school. And he's now the nurse leader on the eye, ear, nose, and throat unit at Rehab Hospital. And he said, I knew a lot of this stuff, so I went to nursing school instead of going back to Saab. But he's a working, full-time human being. As a result of this. I asked Britt Marie, the innovator, where did you find the courage to say yes when he said, I want to hook up my own dialysis? Act for the patient and think for the population. She said, I found my courage in his face. She said, I knew he could do it. And my mental model of nursing is to say, no, that's not how it works, and it's against the law, and the accreditors will get us, and the Department of Public Health. And she said, I found courage to say, if I act for you, it will teach me something about the population. And then she said, every July 1st, the new nurses come onto the unit, and she trains them how to do dialysis. So she said, I have 6 weeks with these nurses. And so I went back to day one, and I started teaching Christian just like I taught the student nurses. And she said it worked perfectly. She said they wouldn't buy a piece of equipment or do anything in that unit without consulting the patients now. And finally, I introduced Ingrid. She's 64 years old, a wonderful nurse who's been practicing nursing for over 40 years. And I said, Ingrid, where did you find the courage to go from what you've been doing for 40 years to being a coach? And she said, you have to look at me here, because she said, in her Swedish way, she said, when I was a nurse for 40 years, the patients walked in like this. She said they were sick and they went home like this. And she said, I've lifted them up. She said, now they come in, and she said, I moved from being a technical expert to a coach because I lifted them up. And this is what Ingrid told me. She said, this is what the patients told us to spend our money on. So these patients are all on dialysis now, and they're exercising. And so every dialysis bed has an exercise bike, or you can see this guy here. He said, just get me a flat bed and put the bike on the end of it. But when you walk into this unit, it is alive. These patients are well. They have a small problem that they're taking care of themselves, but they're not treated as sick. They're treated as well. And it's a small interim issue that they have to deal with. We've got better patient experiences. The health of the population is dramatically improved, and the cost is a half to a third less. That's an innovation. That's a new design. Find your Christian. Find your Christian, and then act for the population. And what you'll see is dramatic improvements there across the board.